Hi, my name is Tenzin Lamo and I'm in N722 class. My proposal presentation is to educate nurses, staff, and families on risk and early recognition of delirium in the hospitalized patient. Some facts about delirium. In the hospital, delirium is common, it's dangerous, and it often goes unnoticed or undiagnosed. 40% of the hospital delirium is preventable through use of Hospital Elder Life Program or HELP. Patients with delirium stay in the hospital longer and are more expensive to treat. Delirium is not a neurocognitive disorder or psychiatric disease. The incidence of delirium is high. It is associated with increased mortality and increased morbidity. The objectives for my proposal presentation include to overcome existing barrier regard to delirium care. ANA in 2016 conducted survey and they concluded that there is knowledge deficiency among nurses to care for patients with delirium. They also found out a lack of continuity in nursing assignment forms a barrier to care for patients with delirium. Second objective is to proactively promote family on how to prevent or spot delirium, signs, educate, advocate for it, and watch for the symptoms. So during the survey conducted by ANA in 2016, they found out roughly 50% of the nurses are comfortable caring for patients with delirium. However, rest of the nurses who participated in the survey are not comfortable in caring for patients with delirium. Therefore, there is a scope for the improvement. Defining the conceptual definition, delirium is an acute fluctuating syndrome of altered attention, awareness, and cognition. Operational definition, it's something that we measure on the floor. Look for acute change in attention, altered mental status, or disoriented mental status. For this project, I would like to promote awareness and monitor risk factors by educating nurses, staff, family members about the signs of delirium at every hospital admission. During the recent theoretical critique assignment, I read up some articles related to theoretical framework on delirium, and this is the one that I like to focus on. Delirium care pathway. It was developed by Albert et al. Between 1990 to 1992. It's designed for routine use in the hospitalized older people by non-clinicians. However, it's also useful to the clinicians and caregivers in managing delirium across a range of care settings. Excuse me. It is a screening tool based on interview of the admitted patients over 18 years of age. The decision tree helps to categorize patients into delirium prevention group or management group. Once the patients are found out to be in the prevention group, this model, prevention of delirium in hospital 4M model, will be useful. The components of the 4M models. What matters? Hospital stay or the ICU stay. Medications. Any new medications added to the patient's regimen. Before any medications added, it's wise to consult HELP program in the hospital for their recommendation. Mentation, monitor any changes in mental mentation from their baseline. Mobility, early mobility helps to bring physiological condition back to normal. FOAM model was developed by John A. Hartford Foundation and the Institute for Healthcare Improvement in collaboration with American Hospital Association and the Catholic Health Association of the United States in 2017. The goal of this model is an age-friendly healthcare system, shift in how we care for the older adults. It's evidence-based practice. It is reliable and applicable across different settings. For my project execution, I'll organize the team, apply the strategies, implement the project, measure the outcome within a certain time frame. Organize team members. They should include each and every individual who come across the patient in giving care, like nurses, nursing assistants, doctors, families, occupational therapists, physical therapists, social workers, case managers, strategies, general one, education. Nurses and family will be provided education on risk factors, signs and symptoms of delirium, information on signs and symptoms of delirium, in general, simple instruction on leaflet or pamphlet will be distributed across the hospital. Also, inclusion of delirium status on the shift report. Strategies with nurses. Educating nurses on using delirium care pathway model for screening at the time of admission. Encouraging them to use FOAM models if they find out the patient is non-delirious for prevention. Encouraging primary nursing to promote continuity of care and to understand each and every patient better to their baseline. Families and staff education. General, easy, simple to understand instructions regarding signs and symptoms of delirium will be provided to the patient's family member and interdisciplinary staffs, like new changes, problem with focusing, confusions, which are typical signs of delirium. Also encouraging family members who to report to. This encouragement will help family member to be confident and to be proactive with watching for delirium signs. Distributing the pamphlets or the written instructions, or putting it on the room's iPad, or putting up flyers in the room will increase accessibility of family members and other staffs regarding prevention or caring for the delirium patients. To implement my project, I would proceed with pilot project first. I will adopt SPARCS, Plan, Do, Study, Act model to screen and to assess delirium at every admission and every shift change. Educate family, patient, and staff. Collect data and observe the pattern and the loopholes. Improve on the drawbacks and repeat the PTSA cycle. These are the expected project outcomes. SHIP report will have a delirium status included, which is currently not at the UW hospital. Nurses will use FOAM models to prevent delirium and delirium care pathway model to assess for delirium at the time of admission. Education. All the patient and their family will receive delirium education at the time of admission and throughout the stay in the hospital. Interdisciplinary team and families will help with monitoring and reporting the sign of delirium. Time frame for the project. December 5, the team members and the champions are due for in-service on delirium. December 15, staff education in-service for general, all the staffs due. December 19th, pilot project will roll out on B6X, UW Hospital and clinics. PDSA Cycle 1 due on December 31, 2019. And second cycle of PDSA will be due on January 5, 2020. And all the improvised final draft on delirium prevention education, delirium prevention material will be in full-fledged at UW Hospital on January 15, 2020. Improvised delirium risk and symptom education project rolls out across all the inpatient unit of UW Hospital and clinics. Implication to practice. Practice change. Delirium will be screened or monitored every shift, every day, and all patients will be screened at the time of admission at the UW Hospital and clinic. Paradigm shift. UW Hospital and clinic will proactively screen, assess, and monitor for delirium instead of being reactive. These are my references. Thank you for listening, and all the feedback are welcome at tilhamo@vis.edu. Thank you.